Thank you for making time out of your day to attend this panel where we'll be talking about advanced care planning through a DE&I lens. I'm really thrilled to be joined by Dr. Bower and Dr. Batra. If you are ready, you can go ahead and turn those cameras on. Just to give everyone some context, Vital Decisions made a decision late last year to offer a series of panel discussions and roundtables with various professionals from the industry to do some sharing of thought leadership. And so one of the topics that seems really important to all of us is the ACP and then DE&I. So that's the focus of our conversation today. The 45 minutes is going to go incredibly fast. I do want to let the audience know that this session is being recorded, and there will come a time in the future, in the upcoming days and weeks, that you'll receive a copy of this. My name again is Connie Ducaine, and I have the pleasure of being the host of this panel discussion, and I'm going to periodically interject some questions, but our primary speakers are going to be Dr. Batra and Dr. Bower. So Dr. Batra, I'm wondering if you wouldn't start off by doing a brief introduction.
Absolutely. Thank you for inviting me, Connie. Good afternoon, everyone. My name is Dr. Romilla Batra. I'm a primary care physician by background, and I'm a chief medical officer for Scan Healthplan. And for those of you who do not know Scan Healthplan, we are a Medicare Advantage health plan. We serve Medicare beneficiaries, a not-for-profit plan that was founded almost 48 years ago by 12 angry seniors who strongly believed there was more to health than doctors and nursing homes, and wanted to stay healthy and independent in their own aging settings. And so that has been our mission and North Star for the last 40-some years. We are based out of California, have about 220,000 Medicare Advantage members that we serve. And in addition to serving Medicare Advantage MAPD members, we also serve special needs plans like those with diabetes, those with heart disease, end-stage renal disease, as well as a lot of focus on dual eligible population. Very excited about our quality of care. We've been a 4.5-star plan for the last 4 years. So based out of California, we are the Lakers for MAPD plan, as I would call it, with the 4 feet, and excited to be joining here to the panel today.
Thank you. Dr. Bower.
All right, thank you, Connie. I'm also very excited to be here today and looking forward to this discussion. I'm Kim Bower. I'm a medical director for palliative care programs at Blue Shield of California. And I also work with our Medi-Cal members around case management and population health initiatives. And Blue Shield of California has about 4.5 million members across the state of California. It's also a not-for-profit insurance plan, and it covers all lines of business. So we have Medicare Advantage, we have Medi-Cal, and we have our commercial plans as well as plans that are sold on the exchange. I think around the area of advanced care planning and palliative care, we, of course, as all plans do, have our hospice benefit, and we have lots of case managers and social service professionals to start advanced care planning conversations with our members. But I think one of the unique things is that we've invested in a home-based palliative care program for people who are not quite ready for hospice, but who really need an extra layer of support at home, an extra support in making decisions and controlling symptoms and navigating the healthcare system.
So thanks for being here. So when we're having our conversation about DE&I and marginalized population and those who are vulnerable, we'll really be talking about it from multiple lines of business, right? And so we always knew that there were inequities that were occurring in the system, but I think COVID has sort of put a spotlight on certain areas. And so now the inequities became more apparent to some. And I'm wondering, as plans, what now has been highlighted for you, how you are addressing those opportunity areas, if it's changed the way you do any segmentation or how you steer innovation. Really curious to hear about the impact that COVID has had in your worlds.
I can kick off if you want, Connie. You're absolutely right. You know, when the pandemic hit, we are based out of California, we were hit the hardest. And as we galvanized our workforce and reaching out to our members, the thing that came to my mind as a primary care physician is, oh my God, people must be, lacking access. And what became apparent very quickly wasn't the medical access they were lacking. They were truly lacking social needs access. So most of the calls that we were making out, we reached out to about 160,000 members over the course of last 14 months, one-on-one outbound calls. People were initially lacking food. People were initially lacking caregiving help in their home settings because their informal caregivers could no longer come into their home setting. People were lacking simple supplies like groceries and homemaking kind of things. And then last but not the least, people were lacking human connection. They really were feeling lonely. And even though we were all quarantining and physically distancing, people were feeling socially distanced too. So that became very, very apparent during the pandemic. And as we were reaching out, we were looking at data in terms of how could we organize ourselves. And you're absolutely right. If you look at disparities, this is not a new thing, right? We have known disparities always existed. But what became apparent for us is as we started looking at certain zip codes and certain geographies, especially the ones that CDC highlights as high social vulnerability index areas, that's where we were seeing all these social needs. That's where we were seeing the COVID impact, the morbidity, the mortality, the lack of access. And so for us, that was the pivotal moment where we decided this is where we crossed the Rubicon. And we said, well, healthcare equity or health equity is not going to be our COVID strategy. Health equity is going to be our strategy, period, end of the statement. So our strategic refresh now has health equity, which is both DE&I as a core, as a heart of who we are. And not only how we serve our members, but we are a not-for-profit organization, but also the communities that we serve. So that's how we have kind of turned around and started looking with a different framework and adopting those kind of things.
Yeah, I would totally agree with everything that you said about how this pandemic has highlighted the really social drivers of health in our communities and how important relationship is. Like when we can't have a relationship, it highlights how much we yearn for it and miss it. And you think about our elderly, some of our elderly population, disenfranchised elderly who were isolated before the pandemic. And then you see this type of effect across the whole population. So going forward, I'm thinking more about relationship and how can we foster those things. And even when most of our members can go out, what do we do for our members who still are socially isolated? I think, the pandemic has certainly highlighted health disparities. We know that when people started losing their jobs and they started losing their employer-sponsored health insurance, about when you look at the proportion of minorities who lost their insurance versus white people, twice as many minorities lost their health insurance and have had to go into either buy insurance on the exchange or go into safety net, get Medicaid programs and insurance that way. But then what we also know is as we went out and we started trying to engage people and get them to get vaccinated and things like that, the systems that we could easily set up were go online, register, drive in your car, get in the line, get your immunization. But those are not systems that are easily, like people don't have cars, they don't have computers, they can't. So just inherently, the systems that we designed for ease and just to get things going fast favor people who have those resources and can access them. And I think the other thing is what we're seeing now is people don't trust the healthcare system. They don't necessarily trust their providers. We're seeing all this vaccine hesitancy, and I think it's just highlighting a lack of trust that's been there for a long time, but now is really showing up.
Yeah, so a few of the threads we'll sort of pull on as we're having our conversation. One I think we'll sort of attend to later is the trust factor. What are we going to do there? The other piece is the DE&I component. So I know advanced care planning is important to both of your plans. And I'm curious about the DE&I lens. So I know from a Vital Decisions perspective, we've always looked at advanced care planning from a culture, from an SES, from a gender, from a generational cohort, so that's always informed how we do the work. But I'm wondering how DE&I is now informing your work in regards to advanced care planning when you think about the marginalized and the vulnerable populations.
Yeah, so you're absolutely right. We have always used those lenses. In fact, we have always gone upstream, and CMS requires us to do health risk assessments on our special needs population. But over the last few years, we have pivoted and started doing a mini HRA, I would call it, which is inspired by Prepare, that kind of weaves in the social determinants of health, and we've started doing it across our entire population. Mm-hmm. So we are asking them those very specific questions to understanding them, like what languages do they speak? What race do they self-identify themselves in? What difficulties they have around social needs, whether it be housing or financial or transportation or food. So we've been building on that database for a long period of time in order to kind of galvanize and do something differently. But as Dr. Bower alluded to, trust was a big thing that kind of came out as we were reaching out to people. And we realized that we have to hear to be, first hear and then be heard kind of a philosophy. And so what we have started doing is, in order to gain trust, is not only focus on our membership, but focus in areas that they live in. And the good thing about us is, since we are a community-based organization as well, being a not-for-profit plan, we are partnering with where people trust the organizations, with them to spread the message. So partnering with churches in the African-American high-density areas, partnering with community-based organization in the heavily populated Latinx areas, using non-traditional workforce like community health workers and training them around the Conversation Project and training them about Prepare for Care, the 5-step process to ACP. So they can then utilize those platforms, the churches, the promotoras, so that people can gain that trust in order to further our advanced care planning strategy. Because to your point, we've done advanced care planning for many years and tried to kind of chip at it incrementally, but this is a little bit of different approach. And I think this came into being because as we were thinking of getting people over the vaccine hesitancy hump, we started partnering with these organizations, and now we're like, we should partner with them, period, to gain trust, whether it be for taking your medications or advanced care planning, get people to where they can feel that they are in an environment where they can trust the people who are telling them how to do it or have that dialogue. And so instead of us facilitating that dialogue, we're having these resources facilitate that dialogue.
Yeah, I think that's one big plan or big questions for all the health plans is, how does a health plan become embedded in the community and become a trusted member of that community? And right now, I think, again, health plans are often seen as the big bad payer who just says no and doesn't give you the services that you need. And so we're starting from where we have a lot of progress that we need to make. I think, we've done a lot of the things that Dr. Batra explained. We've opened community centers where we can have social workers, so people can come in and talk to a social worker in their community. The people that we're hiring for these community centers are from the community and look like the community, and hopefully can develop those trusted relationships. We're leveraging community health workers. Again, they're not licensed medical people, but they can be translators and understanders and help us understand, like, what's the community perspective and how do we help the community understand advanced care planning and the importance of it, while respecting the culture and the norms within that culture and how people communicate. And I guess the one other thing about equity is, one of the things we've seen during this time in palliative care is this huge explosion of telehealth, and everybody wants to use it, and it's so powerful, so powerful. But a lot of our lower income, members that we serve don't have access to always internet and computers and all of these things that we're leveraging. And one of my concerns is we're going to stop having so many people in person in the community, and we're going to rely a little too heavily on telehealth. And then again, it will widen some of those disparities that we see.
I think digital divide, you're absolutely right, is a very big deal. In the beginning of the pandemic, we saw this uptick and everybody glomming around telehealth. But I think the pendulum goes this way and that way, and there's a very middle that it needs to be on. And you're right, I've been proposing and saying, hey, just like we're talking about social determinants of health, Wi-Fi is a social determinant of health, right? So some folks may know how to use it, but may not have a Wi-Fi or have a spotty Wi-Fi, or have a grandkid who perhaps has an iPad and can use it and cannot use it. And I think for us as health systems, we have to think about how do we get care to people in the way they want it. And so, I hear the word digital first and high touch and low touch. And so in our organization, we're like, there's high touch and low touch and high tech and low tech. At the end of the day, what people care about is the right touch. Mm-hmm. So for some, young and healthy older adults, it's like, leave me alone, I got it. For others, how do we supplement it? Like, could we really address the digital divide? So few of us, our partners, we partnered together and dropped off those devices in people's home, like the grandpads, right? You just little one button, you just touch it and you get connected. And we saw the uptake. Like, wouldn't it be cool if we could do something similar for people who want to engage in those kind of discussions with the caregiver alongside them, maybe their social worker sitting somewhere else, so we can scale these interventions too, because that's the other thing we have to think about is if there's something good that's happening, how do we scale it?
True. So it's interesting, I think about the work that we do and the digital component, right? So we've been working multiple lines of business for a long while. And the strategies that we need to leverage for individuals that may be in a different market of a lower SES are different than they may be from someone who's fully employed making a, six-figure salary, right? And so, like you said, it's not one size fits all, not one size fits all. Telehealth, not one size fits all ACP, and it's the right intervention at the right time for the right people, for all of the services that we provide. So, one of the things that's interesting is it's giving just the right amount of service. And I say that because sometimes people would be speaking with us on a phone that they had limited minutes, right? And the intervention that we need to do might typically take 25 minutes, but they only have X number of minutes and they don't want to spend their limited minutes on this intervention. And being able to shift and be with them and say, let's do what we can in the time that we have together, and then pick it up at another point and be able to be fluid, not to be stuck into, well, I have a checklist, or I have a form, or I have a this, or I have a that. Let's be there with the person. And I think that's how we start to build the trust. That's lacking, right? You both said so many things. I was sort of taking notes here about, and I'd like to sort of go back a little bit to language, right? So what are you doing around language, whether that be spoken language or written language, to deliver, whether it's ACP or any sort of services, in-home palliative care, to meet the language needs?
Yeah, I know for us, we're based out of California. And actually, if you look at it, we have a very heavy footprint in both Northern and Southern California. So we have not one or two languages, we have like 5, 6 different languages. And you're right, when we thought about D&I, it's one thing to say we are culturally competent, but it's another thing to understand, recognize that we cannot be culturally competent if you're using just the translator, just the interpreter. It's just not the same. And I think in 2 areas, you really have to think hard about it, is behavioral health as well as advanced care planning. So we have, CMS requires us to take our most prevalent language and have everything available in those educational materials. We've gone 2 steps further. I mean, we have said, we're not going to stop there, because we serve so many more languages. Now, granted, we cannot do 10 languages, but let's get to our top 3 or 4 languages. And so with that in mind, all our content, whether it be our website, whether it be our educational materials, we are translating in that language. And then we're asking people, it's not right for me to assume just because your last name sounds Indian, so you speak an Indian language. Let's ask people, what language do they want to be communicated in? And then let's see if we can provide them. It's easier said than done. Like, how much can we have the member-facing folks speak the language that the members are speaking? And then on provider-facing too, can we match people or help match people with the providers that speak the same language? And if not the provider, maybe the nurse practitioner speaks that language, maybe the lead medical assistant. So we've been looking at a 2-year roadmap, and how do we match people to their language needs and deliver the content? As far as advanced care planning goes, that's why we like the Prepare for Care. We've used Prepare as an advanced care planning tool, because they do offer that culturally and linguistically appropriate advanced care planning that, my case manager, social worker, or community health workers, or my palliative care team can use and kind of furthering that discussion. But I think that's a big thing that we have to start thinking about. It is, being a primary care physician, I recall like being in a room and not getting the translator and the phone going back and forth like that. It's just not the same. Mm-hmm. So we have to figure out what should our workforce look like, and now that to your point of telehealth, if I'm based out of California, doesn't mean that my social worker has to be based out of California. Maybe I can recruit a Spanish-speaking person in Arizona or Nevada. Like, how do I think differently about meeting the needs of the population?
Dr. Bower, any thoughts?
Yeah, that's an important question. When we look at our Medi-Cal population just in San Diego and LA, there's over 100, significantly over 100 languages that our members speak. And so, we have our 5 most common languages and we have materials all translated into those languages, but it's more than just the language when you're talking about advanced care planning. You could say the exact same words to somebody from one culture as you say to somebody in the other culture, and they could be heard in very different ways. So I think advanced care planning really has to start with listening to people's values, their priorities, hopefully developing some understanding of the culture, which I think again is where our community health workers and our healthcare partners within communities can come in and help us understand how do you present this material in a way that is culturally competent and allows people to hear it and not have an immediate negative response to that. And I think in palliative care, that's a place where we have a huge growing edge, is to create materials that aren't just translated from English into all these other languages, but are really focused on different cultural perspectives.
Mm-hmm. And I think about palliative care and how there are cultures that at first blush are not receptive because the perspective is that I should take care 100% of my family because that's what we do. And the idea that someone else is going to engage in that process makes the caregiver feel about their role and their identity, right? I do this. I'm the daughter. I'm supposed to do this, and really embracing that and knowing that people they react culturally to certain constructs in a way that we might not. I think about you've said so many things. I think about the language component, right, and how it's not ideal to use a translator. And then though for those practitioners that might be on the line that don't have access to native speakers, what I have found from a translation perspective, that there was a sense of appreciation for my at least trying, right? Mm-hmm. To try to communicate with the individual mm-hmm. in their preferred language, as opposed to trying to force them to understand mm-hmm. mine. So in a perfect world, we'll meet them where they're at with the native speaker, someone who can really embrace it. However, for those who are in this panel, if you don't have that, an alternative is that you've done something mm-hmm. to meet them where they're at. Now, a few times the term cultural competence has come up. And so I think in our previous conversations, we've talked about cultural humility, cultural competence, whether they're not synonyms, but how they integrate together is a conversation probably for another panel discussion. But I'm wondering what your organizations are doing to help people elevate their level of cultural competence or cultural humility, how that fits into your DE&I strategy.
I think when people talk about advanced care planning or talk about their values and wishes, there are, when a patient comes into the healthcare setting, they're thinking all the doctor wants to know is my medical history. But when they're making decisions, all of these things that you're describing, Connie, the way a family thinks about what gives the caregiver value, or what makes me good or what makes me bad, or what my religious beliefs are, or all of those things, people don't naturally tell their healthcare providers. You really have to give them permission and space, and it often comes out over multiple conversations and over a period of time in terms of trust building. So I think as we, address these issues and design systems, we need to start thinking about these as ongoing conversations, one after another, where trust is slowly built and you slowly understand all of the factors that are coming into people's decision making. So it's a very long way to say, what is Blue Shield doing? Well, I think one, we're trying to understand our members' cultures and race and ethnicity better. And two, we're trying to train people to be empathetic listeners and not always be the first, like trying to teach and deliver information, but first understand.
Mm-hmm. Yeah, and I agree with what Kim's been saying. For us, we also took a step back and said, hey, look, let's start with our own employees, right? Well, they deliver all this care in one way or the other to our membership. Like, we should ask them, what do they feel comfortable with? Where do you think our blind spots are? How can we learn from each other? And then how can we align incentives that we continue to continuously improve? So the few things that we have done over the course of last 1 year, we all have been trained on implicit bias training. We all went through implicit bias training. We, all our members are facing staff have also been through behavioral health first aid, mental health first aid training, so we can understand what it is to have those kind of conditions. And then just like you think about grand rounds 3 times a month or 4 times a month, we kind of have grand rounds across the whole organization. So they're not limited to just the members facing folks, where we bring different viewpoints from different thought leaders, just like we are doing here. So we have folks from NPR speak about diversity, equity, and inclusion. We'll have clinical folks talking about it. We'll have policy-making folks talking about it. So we can expand our horizons. And then internally, we are having those conversations in our staff meetings and huddles. And this year, I'm so excited about our organization. We said, we are not just going to talk the talk, we're going to walk the walk. So we do something called the Gallup survey, which is a survey that you do around employee engagement. And we looked at our results, and we do fairly well. We are in the 92nd percentile in the whole healthcare industry. But when we looked at the data for our employees based on the race of our employees, there was a difference between employee engagement between African Americans and Latinx populations and white populations. And so that was interesting. I mean, we hear about health disparities, but we were seeing engagement disparities, like my voice is not being heard and things like that. And so we said, you know what, this is where we're going to start, because we need to first know, be heard, be hearing our own people before we start, doing paying forward kind of a thing. So for our corporate goals this year, for all our directors and above, our goal is to reduce those kind of inequities or disparities in our employee population. So when we repeat the employee engagement survey, what we have pegged and said is, it doesn't matter if you are the CEO or you are a director of legal or finance or healthcare services, that within our teams, we should be able to meet the needs of our employees. How do we close that gap? And so that's how we have started. In addition, we are looking at our members, and as we are talking to our members, we are bringing them in. So we have community advisory councils. We also do a very cool program. I love this program. We call it Member to Member, where our own members are our employees part-time, and they engage with our membership in addressing sensitive areas like incontinence or mental health or physical activity. And our hypothesis was, if you're talking to somebody who's your peer and who's talking to you about these difficult things, like how your mental health, how would it be? And it's done really well. So we are getting input from all those folks to say, hey, how do we learn first before we start devising programs and training people? Like, what is missing? What are we not getting to? So multiple efforts going on across the organization. And I think the one thing that has helped us is, initially a few years back, we were just focusing those efforts on our member-facing folks. Now we are doing it across the organization. Doesn't matter you're legal or HR or finance, we all should know about it.
Yeah, I totally agree with that. The way an organization approaches this issue comes from the top. And one of the things that I've really appreciated is, at pivotal times over this last 2 years, our CEO has come out and made public statements, and he's emailed them out to the whole organization and, made them public, like after the George Floyd verdict came down, at some of these important times, saying, we stand for diversity and equity, and we stand for justice, and we want to see that across society. And I think that goes a long way in terms of developing over time, hopefully, more trust, which again, I think is so lacking and so fundamental.
And it's interesting because I hear you talking about the strategies that you use internally with your employees and your team members and your colleagues, and we're in a similar space, right? Where we're doing the same sort of thing, because it feels disingenuous if it's outside only but not inside.
Yeah.
And so we've been doing work internally, but we're also mindful of what DE&I can influence externally. So that thread is pervasive in all of our organizations, which is, we talked earlier about, you have to do something, and this is something really meaningful that can be done. It's more than just the talk, it's actually doing, and one of the things I think is important, and we've talked about it before, it's one of our, it's really important to the whole process, is that whole self-awareness and self-reflection and getting to know your own self and what your perspective is. And you mentioned it, the implicit bias, the idea that we all do have them. And, for the longest time, people, I think, tried to say, no, I don't. And the reality is, let's get to our core. We have something, let's find it. And so I was happy to hear you talk about that work being done, right? Because it just makes us more authentic across the board. We talked about trust quite a lot. We've talked about cultural competence. Is there any more that you can share about, you talked about behavioral health, 911, and those sorts of things, training on listening. Are there other strategies you're using to help build trust? For example, in our world, we're a heavy user of motivational interviewing, right? We're going to meet people where they're at. We're going to listen to them differently. And that has a huge impact on the relationship that's fostered. Are there other things similar to that you're using, or are you too leveraging motivational interviewing as a foundation?
Yeah, for all our member-facing staff, they're all trained in motivational interviewing. And in fact, we don't stop there. We understand we are part of the whole ecosystem. The care is delivered at a provider level. So how do we bring our provider delivery system along the way too? So a few years back, we kicked off what we call an office staff training process, where we are not only training providers, we are training their staff, because their staff is the one that's engaging with their patients and our members. And so we are training them around senior sensitivity, we are training them around cultural competence, we are training them around motivational interviewing, because the ecosystem is just not us. It has to be our delivery system, it has to be our vendors, it has to be our transportation vendor. And it has to be folks beyond that. So we do something called Trading Ages. It's a training where all our new employees go through it, but we also do it for our providers, where we go through these simulation exercises to teach them how it is to be in shoes of older adults. How do you see? So, you bandage your arm. We just started doing it with virtual reality, so people can understand, what happens to your vision, what happens to your hearing. How is it when you are a front desk staff giving a 3-inch font form to be filled out by an older adult? And so we've done that trade, we call it Trading Ages. We've done the Trading Ages training actually for our policymakers too, so they know how it is to be in the shoes of an older adult. So a lot of effort is dedicated not only internally, but how do we bring our delivery system along the way so that we can together create this seamless experience from a member perspective? How do we onboard better? Like, what should our onboarding look like? And so those are the kind of things that we've been working on.
Yeah, I agree with that. We do a lot of that training and do training in motivational interviewing also. But the other thing that I think makes a huge difference is that we have a very, especially for our Medi-Cal members, a pretty significantly sized social service team. And those social workers, beyond the training that we're doing, they have their years of training in motivational interviewing and other communication skills. And so we really leverage them heavily with our members in terms of communication.
You know, we've been talking about culture and appreciation of differences, and it makes me think about, you know, oftentimes people think about culture as race, ethnicity. Maybe they'll think about spirituality in there. But when you think about it, it's age, it's generational cohort, it could be birth order, it could be personality. An introvert is going to handle situations differently than an extrovert. And helping people, providers included, to see that the person is very complex, which can be difficult to unpack in just a few minutes, right? We've been asked also by providers, by various groups to say, could you come in and talk with us about the utilization of motivational interviewing as it relates to ACP, right? Because we have a customized application. But we've also looked at 16 factors that impact ACP, and it's race and gender and ethnicity, but a host of other factors as well. Because one of the things that I learned when I was doing the work is I would talk to patients and I would say, does your doctor know you as a person or do they know you as a patient, right? And they always knew what I meant. And they would say they know probably me as a patient because they know what's in the file. And I would ask them, what would be different if they knew you as a person? And they'd say, well, my treatment would probably be different because they'd know I like to go bowling with my grandson on Wednesday night and I can't because that's my dialysis day. And so it's about helping the provider and the patient to have a conversation about what matters to me. And I think, Dr. Bower, you sort of started there. You got to understand the values and the priorities of the person before you can necessarily help them to solve whatever it is you're helping them to solve. Okay, so we have about 8 minutes remaining, and I have a couple of questions that I see here, and I have a question still remaining, but I wanted to give both of you an opportunity. Is there other thoughts that we've sort of triggered about DE&I, ACP, supporting vulnerable populations, and where the future is going to go in this area, right? What are you anticipating will come next? What are the innovations? Any thoughts that you'd like to share?
Well, I think, you know, we're continuing to leverage telehealth, thinking about paying for value, trying to move palliative care upstream and have payment models that support interdisciplinary care in the office setting. So, you know, your physician doesn't feel, or your provider doesn't feel isolated and doesn't have that support. I think all of those things will help move palliative care, and again, aligning treatments with goals. I think all of those things will help. And I think, you know, when I think about where do we want to be, just in terms of mindset, I think, you know, we will know that we have arrived as a field of palliative medicine when people are no longer scared of palliative medicine, when they're demanding it, when they're saying, when they're walking in and saying, I want to talk to a palliative care provider. I want you to know me as a person. But people aren't empowered in that way, and they, I think, are still very, very scared of what palliative medicine maybe means in terms of their prognosis.
Well, I appreciate that, Dr. Bower, because one of the questions I was going to ask you is, how will you know when we've arrived? And you've just given us a very clear picture on when we will know, because people will ask for something that they now might avoid. Right? Dr. Batra, any other thoughts?
I think if you take a step back and look at where care is going, the care is going to a very member-centric focus, a patient-centric focus, right? Care where I want, when I want, and how I want. And so, you know, we still, a lot of us still think about, you know, the traditional brick and mortar, you shall come to me and the doctor shall provide it. And I think people are wanting care in different ways, and people are wanting care from different kind of folks too. So if you really think about how we're going to scale all these things, you know, I'm a primary care physician. You can't depend on the primary care physician for primary care physician to do every single thing. Well, how do we equip the primary care physician so they can do the right thing to do is also the easiest thing to do? Can we use non-traditional workforces that perhaps, you know, to Dr. Bower's point, have more trust, because you have a community health worker that you run into when you go to your church, maybe you see them on the Walmart. How do we use those kind of resources so that we can scale these, you know, interventions and make it really happen? And for some, I am like, my mother-in-law is one of them. She does everything online. She shops online. She's been asking me, well, when can I chat with the member services rep online, right? For them, perhaps we kind of leverage the telehealth thing and see how we can get care to them and maybe empower them with some tools that can help them decide for themselves what they want. So I think that's where we have to get to, where people can get the things they want in the easy way without having to think about it, and not having to rely on the primary care physician who's still perhaps in the brick and mortar setting, but getting to the communities, getting to the homes, getting online. Maybe I want to sit with my son or daughter on the kitchen table when they're there for Thanksgiving, when everything else is closed outside, right? How do I have that conversation? Is there a tool I could use to facilitate those conversations for the people who feel more like empowered, and for others who don't, like, how do we get it to them? So I think we have to think from a member or patient perspective. We have to think about scale too, because a lot of these things are amazing. They're hard to scale. So how do we do it at scale?
Yeah. And how do you take all of those things you just discussed and use them to really facilitate a better, more trusting relationship with the primary care doctor or interdisciplinary primary care team? I think being a primary care doctor is the hardest job in medicine right now, hands down. There's so many things that are coming at you. So how do we leverage all of those things to lift up our primary care teams and let people have those relationships where they feel known as a person? Give the time for those relationships to be built in the primary care setting.
Well, we have a few minutes remaining, and I think I'd like to end where we started, actually, before we joined the attendees. And that's where, we shared a lot of information with folks on the in the audience. If you are going to give them one piece, one suggestion, one nugget, what one thing would you want them to walk away with as a result of our discussion today?
I would say that that perfect not be the enemy of good. And so internally we have this new slogan, which is progress versus perfection. So let's not wait for perfection to happen, the perfect data, the perfect care model. Let's start somewhere. Let's start somewhere small. Let's listen before talking, and set up with some key initiatives that will, make sure we are really progressing versus waiting for the perfect to happen.
Thank you.
Yeah, I would agree. And, and if there's not something that you feel empowered to be able to do, like you can't start a program or you can't, Connie, you and I were talking about this before we started, what you can do is learn to listen and learn to empathize and learn to understand. So on that, you can always make a difference on that one-to-one level with a member.
Yeah, and I agree with that. I think my takeaway from all the conversations that we've had, and as I think about this, is it's talk less, listen more, right? And then you can build that relationship and foster trust and see where it takes us. Well, so we are just about at the end of our 45 minutes together. So I want to say thank you to both of you for sharing your thoughts, your ideas, and giving of your time, because time is one of our most precious gifts, and I appreciate having some of yours today. For those in the audience, thanks for joining. We are going to have another panel in the next 6 to 8 weeks, so look for more information, and you will, of course, be getting an audio recording of this session. And again, I want to thank Dr. Batra and Dr. Bower for joining me here today. Have a good day, everybody.
Thank
Thanks
you.
so much,
Bye.
Connie. Bye-bye.
Now.